Afternoon. I am going to be now talking about the use of Janus kinase inhibitors in rheumatic diseases. An interesting topic. We have multiple Janus kinase inhibitors that are available in treatment of rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis in the United States. When these drugs first became available, we felt it was a major breakthrough in treatment of these rheumatic diseases, particularly in patients that had resistant disease. However, with the availability of data from oral surveillance study, medications, it become a little controversial. So I'm going to touch upon that and in the next few minutes. These are my disclosures. And so I'm going to be discussing the role of JAK-STAT pathway in pathogenesis of autoimmune diseases. I'm going to go over efficacy of tofacitinib in RA, psoriatic arthritis, AS. I'm basically focusing on tofacitinib since it's the only Janus kinase inhibitor that's available in Pakistan, and ultimately touch upon the findings of oral surveillance study and see how to interpret the data when using these medications. We're all familiar that, anti-TNF therapy is effective in about 50 to 60% of our patients, and similarly other biologics. And we have also learned that, on an average, one needs to change the biologic in 3 to 4 years. So this clearly suggested that there was a need for, targeted therapy that could be more effective or provide much better control of the disease in terms of inhibiting multiple cytokines, and would be less expensive and widely available. So JAK-STAT signaling molecules, it kind of opened a new dimension in the understanding of inflammatory cascades of autoimmune diseases. So what are these Janus kinases? They're basically cytoplasmic protein kinases, and they play a critical function of signal transduction of type 1 and type 2 cytokines. And I'm going to briefly go over that, what this means. Just remember, there are 4 types of Janus kinases: JAK1, JAK2, JAK3, and TYK2. And we have multiple cytokines, and so they are divided into type 1 and type 2 cytokines, and they have type 1 and type 2 cytokine receptors. And these receptors, these cytokine receptors, they bind with these Janus kinases. These are either with JAK1, 2, 3, or TYK2. And once these, this receptor binding with these Janus kinases, it activates them. It activates these JAKs, which these activated JAKs in turn phosphorylate STATs. And these are 7 STATs: STAT 1, 2, 3, 4, 5A, 5B, 5, 6. So activated JAKs phosphorylate the STATs, and then these phosphorylated STATs, they either form homodimers or heterodimers and enter the nucleus, where they regulate the autoimmune processes. They control the transcription of some of these genes inside the nucleus. So we all know there are multiple cytokines that are involved in these rheumatic disease. For example, for psoriatic arthritis and ankylosing spondylitis, we have IL-2, interferon gamma, IL-12, IL-23. And for rheumatoid arthritis and lupus, we know there is a regulatory role of interleukin-2, interferon gamma, IL-6. And all of these cytokines are basically signaled by this JAK-STAT pathway. Since with this background knowledge, JAK-STAT kinase pathway has evolved a novel therapeutic target for treatment of autoimmune diseases. You see, there's multiple JAK inhibitors, like JAK1 inhibitor would downstream reduce the production of IL-2 cytokine, interferon gamma, interferon alpha, or IL-6. JAK2 would reduce other many cytokines and interferons: interferon gamma, alpha, IL-12, IL-23, IL-6, TYK2. So this targeted therapy is very novel. Not only does it infect one cytokine, but multiple cytokines and some interferons, and all of which are responsible for causing this inflammation in these autoimmune rheumatic diseases. So Janus kinase inhibitors are now considered like targeted synthetic disease-modifying anti-rheumatic drugs, and they decrease signal transduction of the cytokines to the nucleus and result in a decreased inflammatory response. So there are 2 types of Janus kinase inhibitors. The first generation, like tofacitinib or riloxitinib or baricitinib, and they inhibit couple Janus kinases. Like tofacitinib inhibits JAK1 and JAK3, baricitinib inhibits JAK1 and JAK2. And then we have this next generation, which are highly selective Janus kinase inhibitor. And the goal of developing this highly selective Janus kinase inhibitor was to decrease some of the adverse events like anemia, leukopenia. So upadacitinib, UPA, is selective inhibitor of JAK1, may have some inhibition of JAK2, JAK3. Filgotinib, selective inhibitor of JAK1. Deucravacitinib, which is a TYK2 inhibitor and just got approved for psoriasis in the United States and is currently being evaluated in phase 3 trials for psoriatic arthritis. So these are the list of Janus kinase inhibitors that are approved in the United States for treatment of RA. We have tofacitinib, we have baricitinib, we have upadacitinib, and then they're also indicated in some other autoimmune diseases. For the next few slides, I'm going to mainly focus on tofacitinib, since that is the only Janus kinase inhibitor that's available in Pakistan. In United States, the Janus kinase inhibitors are available for treatment of RA or psoriatic arthritis and ankylosing spondylitis in patients that have inadequate response to TNF inhibitors. So I'm going to discuss the data of tofacitinib data in patients that had inadequate response in rheumatoid arthritis or psoriatic arthritis in the next few slides. So this is a study that was published in 2013 in Lancet that showed the efficacy and safety of tofacitinib in combination with methotrexate in patients with active RA that had an inadequate response to tumor necrosis factor. Patients were randomized to 3 doses, either tofacitinib 5 mg twice daily, tofacitinib 10 mg twice daily, and placebo. Each arm had about 130 patients, and the patients were placebo controlled up to 3 months, and thereafter it was an open label study up to 6 months. Those patients that were on placebo at 3 months were then converted either to 5 or 10 milligrams of tofacitinib twice daily. The primary endpoint was ACR20 response, and at 3 months, a substantial proportion of patients on 5 milligram, 41.7%, reached that endpoint compared to only 24.4% of placebo patients. I'm not going to focus on this 10 milligram dose since that is not the dose that's approved for treatment. This light blue line is the 5 milligram, and there was not a big difference anyway between 5 and 10. And those patients that switched from placebo to tofa also they had showed an increased response, ACR20 response by month 6. Similarly, DAS28 ESR score of less than 3.2, which is low disease activity, was also reached in a large proportion of patients here on 5 milligram twice daily of tofa, 14.3% compared to only 5% of placebo. So this study clearly showed that the patients who had an inadequate response to TNF inhibitors responded to tofacitinib. The most 2/3 of these patients who had tried one TNF inhibitor, about 1/3 of them had tried 2 TNF inhibitors, and a small proportion 3 TNF inhibitors. So usually, I don't use 3 TNF inhibitors. If 2 don't work, if 2 have failed, then I change it to the new class of medications because the response to third TNF inhibitor is usually not that good. But the results from the study were very promising, showing tofacitinib was working even in those patients. Similarly, a similar study in patients with psoriatic arthritis that had inadequate response to TNF inhibitors, about 132 patients were randomized either to 5 milligram twice daily of tofa, 10 milligrams twice daily of tofa, or to placebo. And the ACR response at 3 months was also good with the 5 milligram, 50%, compared to only 24% with the placebo. And this response was sustained even at 6 months. Similarly, there was improvement in the quality of, overall functional status of the patient. HAQ-DI scores went down in patients that were getting tofacitinib and compared to placebo. And at 3 months, the placebo patients switched to the medication, and then their HAQ-DI scores also went down. So tofacitinib is also approved for treatment of psoriatic arthritis. Tofacitinib has also been evaluated in patients with ankylosing spondylitis. This was a study with 269 patients that were randomized either to tofacitinib 5 milligram twice daily or placebo up till week 16, and thereafter it was an open label study where all patients received tofacitinib 5 milligram twice daily up to week 48. The primary endpoint was ASAS-20 response at week 16, and this was seen as early as 2 weeks ASAS-20 response, and ASAS-40 response was seen as early as 4 weeks. 56.4% of patients attained ASAS-20 response at week 16 compared to only 29% of placebo, and 40% got ASAS-40 response. The adverse events were evaluated at week 48, and there were no deaths, malignancies, MACE, interstitial lung disease, diffuse liver injury, opportunistic infections in tofacitinib up to week 48, so got approved for treatment of ankylosing spondylitis. So all of these studies are showing us that it's effective, and at least when used in these clinical trials, it was overall found to be safe. However, FDA wanted an post-marketing surveillance study looking at the adverse events, looking at major cardiovascular risk factors and cancer in patients taking tofacitinib compared to TNF inhibitors. So this oral surveillance study, the data were published just this year, was an open-label post-authorization safety and non-inferiority study. The study had 3 arms. The one arm got tofacitinib 5 milligram twice daily. There was about 1,497 patients in that arm. Similar number was in 10 milligram twice daily of tofa. And then the third arm was patients that got TNF inhibitors. In North America, it was adalimumab, and in the rest of the world, it was etanercept. And these patients had to have RA. They were basically rheumatoid arthritis patients that were greater than 50 years of age and had one cardiovascular risk factor. So the primary endpoint of the study was non-inferiority, to looking at non-inferiority of tofacitinib with regards to MACE and major cardiovascular events and cancer risk. So what was seen was that the hazard ratio with tofacitinib 5 milligram twice daily was 1.24 higher than with compared to TNF inhibitor. And with tofacitinib 10, it was even higher, 1.43, but I'm not focusing on tofa 10 twice daily since we don't use it at that dose. But the combined, even with the combined 5 and 10 milligram, the risk was high. For practical purposes, the tofacitinib 5 milligram twice daily, the hazard ratio was 1.24 versus TNF inhibitor. Similarly, the hazard ratio for cancer compared to TNF inhibitor, it was all cancers, excluding non-melanoma skin cancer, was high for 5 milligram twice daily. It was about 1.47. It was similar to 10 milligram twice daily. It did not change for 5 milligram twice daily. Even though MACE events were less on 5 milligrams, cancer risk stayed high. And they calculated the incidence rate. The incidence rate for the MACE was about 3.4% compared to 2.5% in patients on TNF inhibitors. The incidence rates for 100 years was about 4.2% for cancer. So they concluded that the risk of MACE and cancers were higher with tofacitinib than with TNF inhibitors in patients with rheumatoid arthritis, and non-inferiority of tofacitinib was not reached. So this study showed that the risk was higher with tofa compared to TNF inhibitors. There were some subgroup analyses done. There were some abstracts presented at ACR. They said there were certain risk factors. They did some logistic regression analysis. They said age greater than 65 years. Smoking turned out to be a great risk factor in these patients. So patients who were between 50 to 65 may have lesser risk compared to patients who are greater than 65. There was another study that was published that looked at patients that had underlying cardiovascular disease compared to those that did not have cardiovascular disease. So those patients that have cardiovascular disease, they're at much higher risk of having more events than patients that do not have cardiovascular disease. Nonetheless, the study showed us the risk is higher, and we need to keep in mind when we are prescribing these medications, we need to get a comprehensive history from these patients regarding their risk factors for major cardiovascular events, risk factors for cancer. The study also looked at the risk of infection in these patients with tofacitinib versus tumor necrosis factor. And what it showed was this green is actually the 5 milligram twice daily, and this blue is 10 milligrams twice daily of tofacitinib, and this is the TNF inhibitors. So they said overall the risk of infection, the incidence rate for infections per 100 years was much higher with tofa, around 41.7 compared to only 34.2 for TNF inhibitors. Similarly, the risk was they then divided into 2 subgroups, age group between 40 and less than 65 and greater than 65. The risk stayed higher compared to TNF inhibitors, this green circle and these, purple, this thing. Then they also looked at all infections and they excluded herpes zoster. Since we know herpes zoster is common with genus kinase inhibitors, so they said, let's exclude herpes zoster and see if the risk is still high. The risk turned out to be still high even after excluding herpes zoster. And the The hazard ratio for 5 milligram of TNF for overall infections was 1.20, and for herpes, all infections excluding herpes zoster was also high. It was about 1.18. It stayed higher than than TNF, but not as high when herpes zoster got taken out. They looked at the incidence rates for herpes zoster in these patients, and the risk of herpes zoster overall was much higher compared to TNF inhibitors, 3.8 versus 1.2, the hazard incidence rates per 100 patient years. Similarly, the tofacitinib, the hazard ratio was 3.28 with the tofacitinib 5 milligrams BID versus TNF inhibitor, and this risk stayed high in both age groups, 50 to 65 and greater than 65. So the study concluded that the serious adverse events and herpes zoster was higher with tofacitinib compared to TNF inhibitors. So the results of this study generated a black box warning on this class of medications. So one, they said that one needs, these patients are at high risk of major cardiovascular events and cancer, and that has to be kept in mind when prescribing these patients. So it taught us that we need to individualize the treatment. It's not one thing fits all. We need to get a comprehensive history from our patients. We need to ask them if they have any risk factors for major cardiovascular events or cancer, and then decide. And age, as I mentioned, was a big risk factor, greater than 65. And in Europe, there has been, they have been approved for treatment of patients, but not for patients greater than 65 years of age. So what do we monitor when patients are taking tofacitinib to avoid these, major adverse events? So all patients before starting tofacitinib need to be tested for active and latent TB. Then those who have positive latent TB, they should be treated accordingly before initiating tofacitinib. Routine TB monitoring should be done while they're on therapy. A baseline CBC with differential should be obtained before starting the therapy, like we do with other DMARDs. And then we need to repeat it in about 8 weeks and thereafter every 12 weeks. If the patient's hemoglobin is less than 9 grams, or absolute lymphocytic count is less than 500, or the neutrophil count is less than 1,000, we should not be starting tofacitinib. And baseline lipid levels need to be obtained and monitored every 8 weeks and after the therapy. And liver function should be monitored. It's not recommended in patients who have severe hepatic impairment. If there is twice elevated AST or ALT, one should not start tofacitinib. Females who are lactating and receiving treatment, they're advised not to breastfeed for 18 to 36 years following the last dose of tofacitinib. So in conclusion, I would say Janus kinase inhibitors are novel targeted therapeutic agents. They are effective in treatment of rheumatoid arthritis, psoriatic arthritis, and AS. Based on the data from the oral surveillance study, they have a black box warning with increased MACE and infections and malignancy compared to TNF inhibitors. Treatment for patients should be individualized and risk-benefit ratios should be considered. Thank you for your attention, and I am available for any questions.